Those of you who weren't here for the Oscars, I won't ask you what you wore. You can see that the hotel has changed a lot. So we hope you like the new Lowe's Hotel. We hope you also will spend some time with our friends from industry. Without their support and your support, this meeting could not happen. Is that about 80 seconds? Yeah, that's about it. So my purpose really for being up here, rather than just being a filler, is to indulge myself with a pleasure, which is such pleasure as introducing the Chief Executive Officer of our hospital, Valley Presbyterian Hospital here in Los Angeles. This meeting also is dependent on people other than yourselves and industry, and that is our friends and our supporters at Valley Press, where we have our Amputation Prevention Center. Mr. Valdespino has been our administrator for many years and our great supporter, and so it gives me great pleasure to introduce to you Gus Valdespino.
Thank you very much, George, and good morning, and welcome to Hollywood or Los Angeles or Southern California or wherever your travels brought you from. And I was just in Chicago for the last 3 days, and it's always nice to get back to the warm weather. So welcome to Southern California. I'm Gus Valdespino, President and CEO of Valley Presbyterian Hospital, and it's always my pleasure to open the DFCon conference and continue to acknowledge the great support and the partnership that we have from David and from George for this conference and from the great work that each of you do throughout the country. All of us from Valley Presbyterian are pleased to continue our sponsorship of the conference and welcome you to Los Angeles and to the Lowe's Hollywood Hotel. As many of you know, the annual Diabetic Global Conference, it says here affectionately known as DFCon, is in its 13th year. Over the next few days, you'll hear from many medical experts and learn about innovations in diagnostic and interventional strategies for diabetic foot ulcers and amputation prevention. Conference faculty come from many countries, including the United States, Cuba, the Netherlands, the United Kingdom, Canada, Australia, Italy, and Belgium, just to name a few. Truly a worldwide conference. Conference attendees come from almost every state in the United States and from more than 30 countries. It is clear that DFCon's experienced faculty, unique schedule of events and seminars is important to podiatrists, vascular surgeons, wound specialists, and other medical professionals from around the world. Before we begin today's program, I'm also pleased to recognize a few of my colleagues who are here today. You've already heard from George, but George, I'd like to always thank you for your partnership and your leadership and your passion in building the Amputation Prevention Center at Valley Presbyterian Hospital. Dr. Zarek Espenson, Ihab Aziz, James Burke, and Babak Kasari are also from the hospital's Amputation Prevention Center, as well as Dr. Lori Burnell, our Chief Nursing Officer at the facility. I'd also like to thank Dr. David Armstrong, who co-chairs DFCon with Dr. Andros for his leadership and inspiration, and to Dr. Joe Mills, who serves as this year's conference course director. And lastly, thank you to Kevin McGovern and his entire team from the International Conference Management for conference planning and organization. Best wishes for a successful conference, and thank you all for your participation. Have a great couple of days. Thank you.
Gus, that was terrific. You got to everyone, which is wonderful. And now we can get on. Ooh, gosh, was that me or my hearing aid or maybe my defibrillator? Touche, or touche, as we say here at DFCon. This is so much fun, and I know this meeting feels like a bit like the family's back together, and it really is. This first session is called the Diabetic Foot in Global Relief: Views from 30,000 feet and up from the soul, if you will. It's traditionally at DFCon. We like to take a tour around the world in the first session, and what we find is, things are tough all over, but they're also terrific all over, and we can make a difference with all the different problems. Many of them are very, very similar, and that's what the overall gestalt is that you're going to pick up. That's German, by the way, as we move through here. But I can't think of anyone to kind of sort of translate all of this into sort of an Esperanto better than a good Professor Bolton. He's our first speaker, and the title of Professor Bolton's talk, the man really who is almost singularly responsible, along with several other people here, in creating this sort of discipline in terms of amputation prevention and the diabetic foot, really than almost anyone else around the world, is Professor Andrew Bolton from the universities of Manchester and Miami, the president of the European Association for the Study of Diabetes. His top topic this year is a master cartographer, maps the diabetes world foot by foot. Will you please help me welcome one of my great mentors, Professor Andrew Bolton.
Thank you very much, David. It's always a pleasure to be here. Last year I started by saying, having seen the titles of the talks, I thought that David was in need of psychiatric help. Having looked at the titles this year, I think he's beyond all help now. So I've already had half a minute, so I better get going. So we're going to take a tour around the world, apart from North America, because most people know what's going on here, and we'll start in Europe. Last year, I started, when I was asked to give what in the world is going on, a rather depressing view of what was going on in Ukraine at that time. And I showed you some slides from the Maidan, and people being murdered. And this machine is a bit slow. I'm trying to move it on, it's not working. The slide mover is not working. It's not advancing. There we are. And some of our members from the European Diabetes Association were amongst the people in the Red Cross uniforms there. I'm trying to get this pointer to work now. There we are. And this was going on. And, of course, many people were killed. Since then, the news hasn't been much better. I think these are dangerous times for us, very dangerous times. And if you look at what's going on now, the Baltic states have brought back conscription. War games are being conducted near the borders continually. The Baltic Shiver was a report on the BBC World just 2 weeks ago. I was in Romania lecturing 4 weeks ago, and some GPs told me that every GP in the country has been asked to give a list of all males aged 15 to 45. Worrying times. Finland are continually having incursions from jet fighters. Even in England, we've escorted many unwanted visitors in the skies, and multiple states have experienced cyber warfare. So I think these are very difficult times, ladies and gentlemen. The trouble is, it's not our members. We have many members from the European Diabetes Association in Russia and in Ukraine, and we're all good friends. Who better friend than Irina Gurieva here now? It's not us, it's the politicians. But I think these are dangerous times, and I think we need to be very careful. But it isn't only a war against each other, and I was in Ukraine. I came back from Ukraine on Monday. And it's so sad to hear my colleagues there, some of whom have been to this meeting, saying, we are going to the hospital and helping people that have lost their legs, arms. 6,000 people dead since last year in Ukraine. It's a tragedy. But the battle isn't only against each other, but of course we have a huge battle against diabetes. Let me start with the update of the European and American Diabetes Association guidelines on the management of type 2 diabetes. And we know for many years there's been a slow increase in the drugs used to manage hypertension from 1950 to today. And we have a large number of drugs. There's been a steady increase. If we look at diabetes, of course, we had insulin in 1922 in Toronto, and then we had sulfonylureas and biguanides. In this country, metformin was withdrawn in the 70s. And for many years, that's all we had in our therapeutic armamentarium for the management of type 2 diabetes. But look what's happened. There's been an explosion, and the explosion continues, of new drugs that we use in the management of type 2 diabetes. And we've just updated, and you can access these free of charge from Diabetology, our journal, or Diabetes Care, the journal of the American Diabetes Association, the new guidelines, an update on the management of type 2 diabetes. And updated are new drugs for oral agents, that is, antihyperglycemic therapy. And now we have the SGLT2 inhibitors, such as dapagliflozin. These are very difficult names to pronounce, and I've been working on that one for a long time, so I won't try the others. But these, I must admit to having been skeptical, appear to be very useful new agents in the management of type 2 diabetes. So we have many choices now, from the thiazolidinediones. Pioglitazone has now been freed from this false suggestion that it caused bladder cancer. The big study from Kaiser Permanente in California shows no increased risk of bladder cancer. We have the DPP-4 inhibitors, the SGLT2s, the GLP-1 agonists, and of course insulin, in addition to metformin and sulfonylureas. But today we're talking about reducing amputation. That's the mission of us, our raison d'etre, if you wish. You'll be hearing from Nicholas Schaper very soon about the EURODIALE study, which is a multi-center study from across Europe. One of their first papers, published 8 years ago, this is 14 European hospitals in 10 countries, showed that the severity of diabetic foot ulcers is greater than previously reported, and there's increasing numbers of neuroischemic ulcers. The most recent paper, I'm sure, just published now online as an e-publication. I'm sure that Nicholas will be talking about this. But this is a study, again, looking at prospectively 575 patients admitted with infected foot ulcers and looking at risk factors for amputation. And they showed independent risk factors for lower extremity amputation, deep ulcers, peri-wound edema, foul smell, probing to bone, fever, elevated C-reactive protein. And they're developing a new risk score for amputation risk for patients admitted in this kind of situation. Last year we had from our friends in Spain the first randomized controlled trial that showed that antibiotics alone in osteomyelitis, local osteomyelitis in the diabetic foot. And this suggested that antibiotics alone can be used in forefoot ulcers with osteomyelitis without peripheral vascular disease or necrosis, showing radiological improvement. This was the patient that I first saw when I came to Manchester 29 years ago, with black hair, by the way, in those days, as a new consultant. And she said to me, take my picture and make sure that we can do something to stop people ending up like this. This lady, you cannot tell, but she's blind. Clinical observation, she can't focus. Clinical observation, she's got a patch. And clinical observation, a central scar from a coronary artery bypass graft. Just started peritoneal dialysis and a bilateral amputee. The outlook for this patient is worse than almost every malignant disease. And we've shown, and a number of studies from Nottingham, from Fran Game and William Jeffcoat and ourselves, looking at the risk, the high risk of all those patients on dialysis for developing foot ulcers. This was a prospective study that's being written up right now. And we showed that if you had an amputation, were on dialysis, having diabetes, 3 out of 4 patients are dead within 2 years. These are grim statistics. We need to do something about this. What other studies from Europe? Well, the burden of diabetes in France, a paper published in Global Health last year. The prevalence in France is estimated to be about 6% of diabetes. The cost of complications was estimated to be 47 billion. Well, that's not quite right. It's 46 billion, not 4.6. The euro isn't that strong. It's almost 1-to-1 now, so $47 billion probably today. I made this slide a couple of days ago. Diabetes is the leading cause of amputation in France, and similar conclusions. We need improvements in screening, prevention, and so on. Here's a paper from the Mediterranean region. And unfortunately, this was only surveying vascular surgeons. Diabetic foot ulcer management and most amputations are performed in tertiary centers. This is included Greece, Cyprus, and other places in the Mediterranean basin there. Endovascular approaches are increasing, and most senior vascular surgeons are involved, but multidisciplinary approach is not established, even in tertiary centers in this region. Worrying statistics. Hyperbaric oxygen, myth or reality, fact or fiction. We've discussed this many times at this meeting over the years. We had the paper from Lundahl in Sweden, published a few years ago, suggesting that hyperbaric oxygen may actually have some efficacy in a small group of people. Then we have Dave Margolis' paper in 2013 from a large base of wound healing centers showing no efficacy whatsoever. 2 years ago at this meeting, we had a Canadian group present, and they wanted to replicate the Swedish study, and these were hyperbaric physicians. They could show no benefit at all for hyperbaric oxygen. That paper is not published yet. Apparently they're still arguing amongst each other how to publish it. That's what I hear. So perhaps this study, and this is just published in the Journal of Diabetes, and it's not yet in print, a Dutch group, 2 negative studies, they say they were published in 2013, that's the Canadian one, and the Margolis. Might the Dutch give us an answer? And they're starting the largest ever study called Damocles, but in the Netherlands, where they will enroll 275 patients in 10 centers. Ischemic ulcers to be enrolled 40 HBO sessions and a 12-month follow-up. So perhaps we might hear the results in a couple of years' time, which will be an important longitudinal study from the Netherlands. Lastly, this year we celebrate our anniversary. The EASD is 50 years old this year. We were founded in Montecatini in North Italy, near Pisa, in April 1965. And on the very date that we were founded, we will be back in the very same place for our spring meeting of the executive. So we are 50 years old, but also congratulations to our very close allies and friends in the American Diabetes Association. They're 75 years old this year. Let's move to South America. I can't give you much new data here because I haven't received some. I have a lot of people around the world who I consult before this talk. And in South America, in the South and Central America region, they have limited data on ulcers, but again they're seeing an increase in neuroischemic ulcers. Few data on amputations. There are major socio-economical problems in many. They have the step-by-step program, which I'll return to when I come to Africa. And they have the step-by-step program in Spanish. And, of course, Brazil, the biggest country, is Portuguese-speaking. Chaired by Hermelinda Pedrosa from Brasilia and Dr. Brava, who may be here from Argentina. Here's some examples of what's been going on in the Spanish treating area. Countries with a basic course completed include Argentina, Bolivia, Colombia, Cuba, Dominican Republic, Mexico, Panama, and Peru. So, muchas obrigado, muchas gracias from South America. Let's move to Asia. This, of course, is the famous Golden Temple in Kyoto, and I'm indebted to my very good friend Shigeo Kono, who's spoken at this meeting before, who leads the WHO Center there for diabetes. And he's leading up a group looking at diabetic foot problems in the Western Pacific region. And as you can see, and as you might guess, these are multiple. And they cover countries from all over this region, including Vietnam, the Koreas, Philippines, Indonesia, and even Mongolia, China, and Japan up here. Here are some figures by Dr. Dialysis. Looking at traditional medicine in the Philippines, the use of guava leaves and wild maggots. Now, maggots are good, but wild maggots might be carrying a disease, especially tetanus, so one has to be very careful. Traditional medicine, therefore, widely used still in some countries in the Western Pacific. And here's the well-known center at Quezon City in the Philippines, which has led a lot of the work in that region. And now, the Kyoto meeting has been going on every year. And they have a meeting of representatives from the region every year. I can't say it was the Kyoto meeting this year, though, because it didn't occur in Kyoto. It was actually in Osaka. Osaka is very close to Kyoto, half an hour by train. So this is their meeting that occurred just 3 weeks ago. And their international advisor this year is our very good friend from Tanzania, Dr. Abbas, who is well known to many of you here and has spoken here on multiple occasions. And the International Diabetes Federation Western Pacific region in the Western Pacific here. This is their advisory board. As I said, they're a very important center there, WHO recognized, in Kyoto. And they have task force and representatives from most countries in that region. They've been collecting data which was reported this year from the Western Pacific region. And some of the data are here. So each country was asked to have at least 20 cases, and most of them achieved that. 2 centers from the Philippines, 2 from Thailand. Even Mongolia managed to get 21 patients. And you see, apart from Cambodia and Indonesia, the majority of foot ulcers in that region occurring in males. Usual age, sort of around the 60 age average, and usual duration of diabetes. Many have a past history of foot ulcers, many, and a past history of amputations. Very high-risk group patients. So to summarize the reports that came from across the Western Pacific region, the cause is still shoes, very common. Shoes very common across the world as a cause of foot ulcers. Trauma, sandals, slippers, barefoot gait. Late consultation, that's a constant finding in most of the countries in this region, very late. Many lost to follow-up, and many patients presenting with advanced ulcers. More patients with end-stage renal disease, chronic kidney disease, hypertension, other comorbidities, and increasing numbers of patients with peripheral arterial disease, especially in China and Taiwan. Smoking very common in those countries. The characteristics of diabetic foot patients are changing, as they are here, to be more neuroischemic. Here's a very recent paper from China, from very many well-known people. 669 foot ulcer patients in 15 hospitals reported from across China. Again, the majority male, usual age, and neuroischemic, 56% now in China. Only 19% resulting in amputation, of which only 2% were major. That's a step forward for China. And predictors of major amputation in their series, higher white blood cell count and a foot ulcer history. Here's a study from Iran. We don't hear much from Iran, other than from our politicians, usually bad news. This is a study published in the Journal of, I can't pronounce that, but a Journal of Microbiology. All infected ulcers admitted to 2 teaching hospitals reported. Nearly 200 subjects. Interestingly, a single organism in 80%. It makes me wonder about their techniques, because that would be very unusual here. 60% treated surgically. 45% undergoing amputation. These are depressing statistics. Response to medical treatment, as you see there. Lastly, from India, they're starting now an excellent program, a diabetic foot education program. They've run 20 workshops across the country, 60 delegates in each workshop, with regional faculty and emphasis on interactive and practical sessions. And you can see right across India, from Kerala and Tamil Nadu down here to West Bengal up here, and Karnataka and Maharashtra, all the states of India are covered by this. And 3 people well-known to you, Dr. Pense from Nagpur, Dr. Vishwanathan from Chennai or Madras, and here's Professor A.K. Das, who is professor at JIPMER in Pondicherry in Tamil Nadu, leading the course. Lastly, Africa. Tanzania hosted the second of the Pan-African Diabetic Foot Care meeting. This was the first standalone meeting last August. Tanzania, of course, is well known for Mount Kilimanjaro, for its wildlife, and for the beautiful island of Zanzibar. But the Pan-African Diabetic Foot Study Group meeting, this was the second, but the first standalone one, and here the Minister of Health attended. It turned out that he had been trained in Newcastle, where I trained, and we had a very interesting discussion. But also, of course, his main reason for that, here he is receiving a leaflet on diabetic foot problems. And here is the faculty, including some well-known people here. There's our friend Abbas, Lynn Tudhope from South Africa, I can't quite see on this one, Vishwanathan there as well. And up in the back was Camilo Barato. Delegates came for this meeting from 9 countries outside of Africa, but from all over Africa, from 19 sub-Saharan and supra-Saharan centers, from all 24 regions of Tanzania. The diabetes prevalence in Africa is going up probably more rapidly than most countries or continents in the world, and this is a continent that can least afford these kinds of statistics. And I thank Abbas for these slides. They've done a lot there on foot care education, and various studies have shown that many of these are important in protecting the feet from complications. The step-by-step project really started in that region of the world. And here is Abbas receiving from the then Minister a diabetic foot stamp in that country. Many countries have now done the step-by-step program in Africa and Caribbean islands and all over. And of course, Christine Van Acker has been very important, especially in the Caribbean, as you see there. The step-by-step project goes on. It's spreading now right across the world, as you see here, even into Europe and North America. Prevention, of course, is important, and simple care, motivation, education, and action by the patients themselves. And they have a lot of workshops in Tanzania bringing patients together with healthcare professionals. So he concludes that efforts are required to increase awareness and diabetes and its complications across sub-Saharan African countries. And of course, early detection is important too. So I'll leave you with a couple of thoughts. Nothing is new in medicine, and Henri de Monville wrote these words in 1320. Anybody who believes that anything can be suited to everyone is a great fool, because medicine is practiced not on mankind, but on every individual. Remember that. Guidelines are good, but think of the patient in front of you. And we are getting many more technologies, and here's the forward-thinking Toffler, who wrote, our technological powers increase, but the side effects and potential hazards escalate with that. Bear that in mind with new treatments. And I will end on the last slide to welcome, hopefully, many of you to what will be now the 51st meeting of the European Association for the Study of Diabetes this September in Stockholm, the beautiful city in Sweden. Thank you very much.